So my name is Andy Goodman. I'm a second-year interventional fellow here at the Cleveland Clinic. I wanted to first thank Dr. Shishabor for the opportunity to speak with you here today at the symposium. I also wanted to apologize for the raspy voice. I'm just getting over a cold, so please bear with me. But I do have 4 cases, as was alluded to. So without wasting any more time, we'll dive right into the cases. Again, they will be interactive. I have a fair number of audience response questions, so please utilize the audience response system in front of you there. Case number 1 is a 55-year-old gentleman with a history of hypertension, dyslipidemia, diabetes, tobacco abuse. Came in with a painful right first toe ulcer with purulent drainage, as you can see there. Had x-ray evidence of osteomyelitis and had PVRs with TBI showing non-compressible waveforms and essentially a toe pressure of 0. So we had angiography. You can see on the panel on the left, doesn't have any significant inflow disease. Selective angio of the right CFA showed that the proximal SFA is all right, but he has some moderate to severe diffuse disease in the mid SFA with a popliteal that looks okay. Below the knee, he has an occluded AT, severely diseased PT that, as you can see, is occluded just around the ankle. He has a good peroneal that goes all the way to the ankle and collateralizes the AT and PT with an intact pedal arch. So this will bring us to our first question. So what would be your next approach for the SFA lesion and or the AT and PT for this gentleman with CLI? DCB of the SFA only, DCB of the SFA with AT-PT reconstruction, atherectomy and DCB of the SFA only, atherectomy DCB with AT-PT reconstruction. Obviously, bailout stenting if needed after DCB. Okay, so we're sort of split between 2 and 4, so DCB, the SFA, and AT reconstruction, and atherectomy plus DCB. Maybe at this time we could open it up to the panel for some discussion about how they would proceed in this particular case.
Well, I think the first thing that is, for me, interesting is how they're expected to do a drug-coated balloon of the anterior tibial and posterior tibial if they're not part of trial in the U.S., because there's actually no FDA-approved DCB in those sizes. So that would be my first thing, unless you're part of the trial or any of the other physicians that answer that are part of one of our trials. Other than that, let me ask Carlos, you just said it. Would you atherectomize from the get-go that SFA and POP with some kind of tandem stenosis? Didn't look that bad?
I don't think so, to be quite honest with you. You know, one of the issues with atherectomy is the issue of distal embolization. I think that in patients with critical ischemia like this one, I will be careful about that. If I were to use it, obviously, I probably would use an embolic protection device. Many say that you shouldn't use them all the time. And I will be curious to see what Kenny has to say about this lesion. This was sort of a typical lesion that we saw in the Levant 2 clinical trial. And those lesions actually responded well to that specific trial. It's a relatively smallish vessel. I wouldn't want to stent it. So I would just pre-dilate the vessel, hopefully avoiding dissection. I would treat the SFA with a drug-coated balloon. I definitely will pursue an intervention in the AT, given the patient clinical presentation. And at this point, probably what I would do, depending how I feel about it after I cross it, I would just angioplasty the AT. That would be my approach in this case.
Dr. Rosenfeld, I kind of threw it back to you.
Let me just ask you, is anybody surprised that this patient has such a impressive ulcer on the toes? Go back to show us the toe again for a second.
Sure.
I mean, it just seems really dramatic considering, although, I mean, I guess, you know, the flat waveform to me looks a little inconsistent with the amount of runoff, because it looks like there's not terrible runoff. I mean, although if you were to angiosome characterize it, might be that there's no flow there. But go ahead, go forward again.
So that precisely validates the need to establish the degree of infection. Because for me, that was probably a small traumatic lesion and has, onychomycosis, has osteomyelitis, and probably even an abscess under that nail that needs to be drained. So I think really that this is one of those that you really want to show the Wi-Fi, because a badly managed infection in a patient, because after you revascularize that, it's like putting fuel into that foot. That foot's going to drain pus all over. So it's very important that you actually do whatever you got to do and then try to open it and drain it and deal with it in the acute setting.
So are you surprised, Miguel, at the waveform being absolutely flat? Given, I mean, this.
I am pretty surprised at it, because there's a PT that's nicely, plantar arch that's nicely at least reconstituted by the perineal.
Well, anyway,
But
so I agree. I would approach this with a drug-coated balloon in the SFA, and probably try to recanalize the anterior tibial. Although you don't really see it reconstituting that in the distal area. You see a little bit of DP there. That's a very thready thing, right on the dorsum of the foot. But I'm not sure. I'm not sure, to be honest with you. I guess I would probably recanalize the SFA, take care of the wound, and then decide, give it a break at that point, and make a decision as to whether we needed anything else to be done.
Sure.
so what do you guys do?
In other words, I'd stage it.
Yep. So I'll move forward. Next question: if you did choose an atherectomy device, which would you choose? Didn't seem that many on the panel would do atherectomy in this case, but give you a second
Gonna
to
get that
respond.
music.
Well, so
Going.
I'll say that if I were to do the anterior tibial and I were to get through it with a wire, then I would laser. This is a good case for laser. It's a lengthy occlusion, and probably use a series of lasers, meaning a 0.9 and then a 1.4, or 1.4 and then a 1.7, or some combination thereof.
Sure.
Or just the 0.9 and then post-dilate it. That's my approach for this the infrapopliteal lesion.
So what did you guys do? You got 1 minute to wrap this case up.
So we first did TurboHawk directional atherectomy, followed by PTA with a 6mm DCB.
What was
And,
your thought process behind the need to do directional atherectomy in this case?
I think the thought process was to debulk a little bit in order to get a nice expansion of the DCB. And
So did you debulk, then plain old balloon angioplasty, and then drug-coated balloon? Is that the way you do it?
so yes, so it was debulk 5mm balloon followed by a 6mm DCB.
I disagree. I would have probably done what Carlos said is, it looked like a fairly amenable diffuse in tandem stenosis. You could probably do it really slow. If anything has been learned from drug-coated balloons, is that we were doing POBA wrong. If you take your time and you're slow, you could probably dilate it really nicely, get a really beautiful result, and then just tack it down with a DCB and be on your way.
Or do a slightly undersized balloon.
Correct.
Which is similar to the slow. They're both slow and undersized.
But
Yeah.
bear in mind, what I think is true may not be the right thing. You may be right.
Of course, totally right.
Yeah, I think that a lot of these cases, not only discussion but potentially debate as well. So
Did you guys treat the tibial?
we did. So we
Which one?
recanalized the PT with a 2.5mm balloon, just PTA.
The PT. Where was the PT narrowed?
It was occluded.
So it was distally occluded, and there were
I missed that.
severe lesions, tandem lesions in the proximal portion, and then in the more distal portion. So
What do you think about that, Tayo?
Well, I mean, I think it all depends on how the wound does. I think you've got improved flow. It's a little bit hard to know if you've increased the perfusion to the target area, the angiosome of interest, but we all know that I think what you pointed out earlier about the infectious process and the disproportionate wound to the blood flow was the issue. So, I mean, at this point, if you have an improved toe pressure and the wound is making progress and you've treated the infection, you may get away with it. But I would not be surprised, on the other hand, if the patient's not making progress, that there's more work to be done.
Did you measure the TBI after the intervention? Just out of
I'm sure they did. I didn't include it in this presentation.
How'd the patient do?
So the patient did well. Had a single first toe amputation, healed well after this. the plan was to do that staged intervention and open up the AT if needed.
You know, this is precisely one of those cases where I feel very passionate about how we really should, as a community and scientific community, try to find perfusion ways to get objective data, because what tells you that he's fine right now? I mean, they just went for the PT. Carlos actually said, I'd go for the AT. I'd probably go for the AT too. Should we go for one or both?
You know,
Is
it's
there any
interesting
need?
that you said that, Miguel. So there's one study, we actually submitted an abstract to AHA, looking at SPECT images. So think about a cardiac stress test. And, you know, we do them when someone has angina, and then we look for mismatch in perfusion. So we did this study looking at feet and seeing if there is such a thing. So we did a bunch of feet before we revascularized them, and there was a clear defect on the SPECT image. And then we revascularized some of them based on the angiosome concept, and you can see that the imaging in the SPECT completely improved in some, but in others didn't. And those that didn't, we did a second vessel, and then the perfusion improved. So to your point is that, I don't know, this is a guessing game. So we go and do the PT and may or not improve, but I don't know, that told the foot for how long it's gonna be viable, and we may be missing the point. Definitely we need a better way to assess a result, and I agree with your point.
Yeah, Dr. Ranyan the other day did an amazing live case where he actually went after this into the PT and then did methylene blue injections. And then he actually uncovers the foot right on the table, and he could see where the methylene blue is going, and it kind of tints your angiosome. If it goes straight to where the ulcer is, then you're kind of safely, you know, following along the same track. And when I've been working with a company called Perfusa that actually has micro-oxygen sensors. You can put them subcutaneously, and you could actually track within 4 seconds of an intervention changes in oxygen tension. So I think that's certainly the next step in CLI below the knee complex interventions. So we're not going to take more time. We're not
Okay.
going to hog your mic. Keep going.
So I'll move on to case 2. This is a 47-year-old gentleman with similar risk factors who came in with a non-healing ulcer of the left foot. He has a mixed venous and arterial ulcer, as you can see. He underwent PVR and TBIs, which are noted there, reduced waveforms, and a TBI of 15. So switching gears a little bit to some of the information we covered yesterday, how to approach a mixed venous and arterial ulcer in this circumstance.
We got to work on some music when we're
That's
doing
right.
the timer.
The Jeopardy theme.
Jeopardy music in the back, yeah, because that's 10 seconds.
We know you can play the drums.
So any comments from the panel? The audience felt C, arterial revascularization ASAP, followed by aggressive compression.
Dr. Hazan, your feelings?
So I
The
think
answer's compression followed by revascularization in this instance, because revascularization will essentially just open up a huge rush of flow to that area and not going to heal the wound until you've assessed the compression adequately.
So I think these are the kinds of ulcers that are actually very, very challenging to heal. Again, there's no data at all, and it's kind of gestalt and flying by the seat of your pants to have a feel of what you think is the best way to heal these ulcers. But I agree that what you just mentioned is probably the best way to go, and see if you get a good result. So you went ahead and did that.
This picture is after they had extensive compression and treatment already. So then we took them back because they continued to have a wound that did not heal after compression. So then we took them for angiography. So as you can see, there's a severe lesion in the mid to distal SFA. Popliteal looks okay. He actually has 3-vessel runoff. I know it's difficult to see on the far right panel.
Can I put an audience participation in here?
Absolutely. It's open mic. Everybody's got a mic in front of you guys.
Well,
Please
I've been
do.
open the whole 2 days, but I'll tell you, I'm a local guy here, vascular surgeon.
Could you raise your hand? Because I have no idea who
Sorry,
you are. Oh, there
hiding
you
over
go.
here. So I'm going to tell you that I'm 100% in disagreement with what you just said, that you treat the venous disease before the arterial disease when you have combined disease. Because if you want to treat the ulcer and get it better, you have to improve oxygenation. You can do it both by compression, but you can do it By arterial revascularization, and I'm going to say that I think when you are in the midst of being stuck with two, you must identify both first, then fix the arterial if it's severe before the venous, because the venous isn't going to make him lose his leg, but the arterial will. So I would not ever, I think, do what you recommended doing. I may be wrong, but I wouldn't do it that way.
And I may have misled a little bit because this picture that I included is after a few weeks of compression therapy. So there was quite a bit of edema there to begin with.
It has nothing to do with the picture, sorry. For 26 years of doing this, I'm going to tell you what matters to me is the flat line of your below ankle perfusion to a mid-lateral foot ulcer, which is being fed predominantly by branches of both your maybe posterior tibial and maybe to some degree secondary branches of your peroneal. But there's no way I would treat that thing with compression for 3 weeks first. I think you got away with it, but that's not what I would do. Be
Agreed.
interested to see what the other guys say, though.
Agreed.
Also, I totally agree with that. Never treated venous.
You got to keep that finger.
Oh,
on.
I'm sorry.
Yeah.
I would not have treated the venous before the arterial. I am also a vascular surgeon.
So a question for both. I am also a vascular surgeon. Apparently, it's like an AA meeting here. Hey, we're here, okay? We're actually amongst the crowd.
But we are the minority.
Yes, we are. Would you guys treat the venous afterwards, or would you wait?
Oh, I would treat them after I revascularize
But in
them.
a fairly short interim.
Right away. I mean,
Correct.
once
Because if you see the clinical aspect, I mean, there's obviously venous changes to that. And I agree with both of you. I would fix the arterial and the venous. I don't know if I would be super strict in saying, one first and one the other, but I would do it within the
you
same
can do them
week.
at the same time.
I could do an EVLT and then at the same time do an arterial revasc. I would do it in a small frame, but I would treat both things because I think that clinically it looks like a venous condition.
I
But
don't
I
think
agree
the
that if you can't put arterial inflow, you're not going to heal it.
Without seeing
I
the
would
whole leg,
agree
I don't
with
think you
that.
can say.
I also have one question. That was just fem-pop disease. Was there, maybe I missed the angio, was there more significant disease below that?
There's not. There's actually 3-vessel runoff.
Okay, because that's what I thought, and that's, so it makes me think that, it's unusual for somebody to have fem-pop disease and have a totally non-healing ulcer below, and I therefore think the venous had a lot to do with it, rather than just arterial. But if you're gonna revascularize because he needs it, then I would say I'd do the arterial. And I would also say that one of the reasons he may have done well with just the venous treatment initially is because that might have been the real big problem here.
Correct. All right, let's follow along so we could get on time.
Okay. So crossing this lesion, what would be your approach? Antegrade 035 system, antegrade 014, 018, retrograde ultrasound guided, retrograde fluoroscopy guided.
I'll let everybody decide, but Philip, what do you think?
I would go antegrade first. The little collateral there may give you some trouble, but there's no reason not to go antegrade first.
And everybody agrees with you.
Okay, most people said antegrade, and the majority said 035 system. So we actually went up and over with a 7x80. We used an 014, we used a Pilot 200 to cross the lesion. Our idea was to stay luminal because we wanted to do atherectomy in a DCB. So we first did PTA with a 25120 because we wanted to do embolic protection for this for Jetstream. And so we first did PTA with a 25120 over the wire because the filter would not traverse the lesion. We then swapped the Pilot for a Viper wire 014, 017 tapered, delivered a NAV6 EPD, and did atherectomy with the Jetstream pathway system. So you can see the panel on the bottom right is delivery of the EPD. So we did 2 runs with the Jetstream pathway, blades down, which is a 2.1 millimeter, and a blades up at 3 millimeters. You can see the angio post atherectomy. We then dilated with the 6120 balloon. So how would you treat that lesion now? Would you do a DCB to finish? Would you do a Viabon, a Zilver PTX, a self-expanding non-DES? Or there was evidence of dissection there, would you do FFR and assess the hemodynamics?
Can you play the angio one more time?
Sure.
Gonna go back one more.
Okay. So most people said DCB and a smattering of other results. We placed a 6/120 self-expanding stent, post-dilated it with a 6.0 balloon, and our results there on the right panel. We could open it up for discussion. I think it illustrates some of the change in practice over time. I think the way that we would address this lesion now is a little different than when we did here. This case was a few years ago. So maybe we could bring that up for discussion.
Yeah, let me start by saying, Dr. Rosenfeld, do you feel that there's still a space to clinically use a laser cut non-drug eluting stent in the SFA?
It's just a loaded question. Yeah, well, let's be honest. I think very few of us are using standard, slotted tube stents now without drug on them, without Supera, without. I mean, I just think it's harder. Although, frankly, the economic benefit we haven't really shown to be really clear. I know that somebody's done a study with the Supera economic analysis and so on, and they're shown to be a benefit. But honestly, I'm not 100% convinced yet, and I just think it's a hard thing to decide. The cost of this procedure. I thought you were going to ask me, Miguel, is with the issue about the use of pathway first, or any atherectomy device first. Now, why not just go to series of balloons, 5 millimeter, then a 6 millimeter drug-coated balloon. It's to what Carlos was saying earlier. We don't know what the hell we're doing. I mean, we don't know what the best thing is to go with first. We don't. I mean, let's be honest. So I love that slide, Carlos, with all the different studies, and they all show varying patencies that are fairly similar, and you don't really know what the endpoints are all over the map. It's great. We just don't know what to do. I mean, I don't know. What do you think, Miguel? Back to you.
Well, I know I would have to agree that the more we do, the less we know, unfortunately. I will say, however, that for femoral popliteal lesions, long stenting, because that seemed to be at least a 15 centimeter stent with laser cut nitinol stents, I think has been shown to be pretty dismal. And so we have changed our practice to either using interwoven technologies for that sort of lesion or drug-eluting stents for that sort of lesion. But I don't know that I would start again with an atherectomy device straight up. I think that you have to have a reason for what you're doing and a thought process behind it, because a plain old balloon angioplasty can let you know what's going to go first with the lesion. I think you could still do balloon angioplasty and then utilize atherectomy device as means to optimize previous to implanting a stent if that's what you're going to do.
Oh, I don't know. That's the one that I'm not sure I buy into, because once you've done balloon angioplasty, you've sort of pushed the lesion back and you're no longer going to get as effective an atherectomy. So I think the decision about atherectomy, you wouldn't use pathway up front, afterwards, nor would you might, the only one that you really might use is directional. I don't know about the device you described, but even with the directional, I think that once you've already done a balloon dilatation, you push a lot of the plaque away from the blade. So I think the most effective time to do atherectomy is up front and to debulk up front. So it's a strategy start with up front. I don't know. Sahil, what would you have done?
I think what Carlos described is exactly what I would have done in this. What he said in the last case is a similar situation here. You wire a balloon, and then see how it looks. And if you decide to use drug delivery, you have two choices. You can use a drug-coated balloon, or you can use a drug-eluting stent. The jury's out as to what's going to have superior patency. This is incidentally not 3-vessel runoff. The AT peters out at the foot. But I think that the atherectomy paradigm you're describing is very coronary-like, in which, in the coronaries, if we decide to atherectomize, we do it up front. Whereas in the periphery, you have the luxury sometimes of doing it subsequently. But most interventional cardiologists are reticent to do that, except for directional. That's the paradigm that I adopt. Since you trained me, Ken, that's what I do.
All right, let's follow with the next one.
By the
Could I-
way,
could I ask one
what
question?
about a coverage stent? Because that's another option out there. It's a little more expensive, but it's a pretty nice result that you get from
First
it.
question.
Sorry.
I'd like to go back to the dogma about the sequencing. Does not the location of that ulcer sort of dictate that the venous is the primary process, which would allow you to treat that first and then revascularize?
So
Because there was no distal toe involvement to suggest that the ischemia was the primary initiating event, that the initiating event was primarily venous.
yeah, I mean, I agree in the sense that I don't think that it's a big deal if you do one or the other or the both at the same time. I would say that they both should be done in a time frame that is short enough. In those patients that, even though they do have arterial component, that they actually are within the critical limb ischemia component, meaning that, let's say, their ABI is below 0.3, or they have a toe pressure below, let's say, 40 or 30, where you know that there's going to be some healing issues behind it. If you have a CTO of the SFA, you have a toe pressure of 65, and you have a decent waveform, well, why don't you just treat the venous? There may be no need for this patient to have any arterial work if you have an adequate, or at least marginally adequately perfused limb.
I think that makes a lot more sense than just dogma of one versus the other.
Miguel, if I may comment on that case, I'm here,
Where?
up here. Yeah.
Okay.
Sometimes it's challenging in these patients, as you know, with mixed arterial and venous disease. You typically ask them, they come in with some rest pain, and when you revascularize these patients, the edema gets worse. So at least my own experience has been that, when you have mixed disease, arterial and venous, if you treat the arterial, then you can be more aggressive with venous compression and wrapping and those kind of modalities. And usually you hasten the healing process. I think that one of the issues that we need to change our mindset from is that not whether the patient got an amputation or not, is that what's the modality that's going to, as fast as possible, heal the ulcer. And I think in these situations where there's significant disease, not treating these, you may be able to treat the venous with just treating the venous. You may be able to heal the ulcer, but it may take 6 months, 8 months, because you cannot be as aggressive with compression because of concern from the flow. And honestly, I feel that we don't have the right modalities yet to assess perfusion that well, to know that, okay, this mixed venous ulcer, well, I'm not going to treat the arterial disease because I think the perfusion is good enough. I mean, if the ABI is normal, then they probably don't have vascular disease. But if you have patients that have vascular disease, the ABI is down, and you have toe pressures that are down, I don't think we have the modality yet or the studies to say that, okay, this patient, I'm just going to treat the venous disease, and I'm not going to approach the arterial, and I'm just going to leave it at that. Just, my thoughts, yeah.
So just to wrap it up, same patient, ABI 0.85, SFA occlusion, doesn't claudicate, hasn't had issues, has varicose veins and a venous ulcer. Would you treat the arterial side?
No, I agree with you.
No.
I mean, that's a different ballgame. So I think
Venous.
that you have to be dynamic. I mean,
Correct.
every patient is different. And again, this goes back to the team approach, having the wound specialist there, having us there, having a team approach of discussing it. And when the wound therapist, when the podiatrist or the individual that provides the wound care says, listen, I've been going at this for a while, and I have not been able to successfully treat this. I think I need your help. I think we have to listen to the team and take a team approach.
Let's pick on the fellow again. How about that? So you want to do we're actually down to 9 minutes, so
Yeah.
it's probably going to be a third case, and we'll
Okay.
wrap it up there.
Sounds good. So case 3 is a 74-year-old gentleman, has a non-healing ulcer on his right first toe. Prior stenting of the right external iliac comes now for a staged right SFA intervention. PVRs are shown here, flattened waveforms at the toe. Angiography, proximal occluded SFA, reconstitutes down near the adductor canal. If endovascular treatment's pursued, what would be your approach to the SFA CTO? Antegrade, 035, antegrade 014, 018, retrograde, ultrasound guided, retrograde, fluoroscopy guided.
Well, the audience responds. Any data in terms of his cardiac status? And did you guys do a vein mapping on this guy?
That's a good question. I don't actually remember if he had vein mapping prior to that. He was 74. He had a lot of comorbidities. I don't remember his ejection fraction, or I don't think he had coronary disease.
I guess my point is, from the cardiac point of view, low, medium, or high risk for a bypass. This is what I'm getting at. And I'm a cardiologist.
If I saw this guy in Dr. Shishibor's clinic, probably high.
Okay.
You mean
I
you'd
haven't
probably
met-
enroll him in the best CLI trial?
I haven't met.
Medi?
Yeah, this
Medi?
case- this
Best
case-
CLI, what's that?
This case was before BEST, and also we have yet to meet a low CLI patient in their 80s that have a low cardiac risk profile, to be honest with you. I'm sure there are a couple out there. Yeah. But I don't remember specifically this case, what the risk profile of this patient was. But I think Carlos has a good point in a sense that you need to know what your options are. Yeah. And if we know that there is a venous conduit, maybe we don't try as hard as we would. And versus if we know there is no venous conduit, we may push the envelope a little bit more. I think that's the point.
And that was also the main reason I put if endo was pursued.
So to be fair, if we look at our operative results here, this is our average patient. So just to provide the surgical point of view,
Sure.
is here at the Cleveland Clinic, this would not be high risk in my clinic.
Sure. All right.
Who's talking?
It's like the anonymous voice.
So most people
We
said
really don't
antegrade
know
035.
Who spoke? Could you just raise your hand so we can? No? Okay. Remain anonymous, it's fine.
That was
Oh, it's Sean.
That was Dr.
Well, hey,
Leyden.
Dr.
That was Dr. Leyden.
I was raising my hand.
I didn't recognize your melodic voice. I'm sorry about that.
Melodic.
Very melodic.
So in this case, the plan was support catheter with a sag wire. Unfortunately, it got subintimal and failed reentry with an 014 approach. So Dr. Shishibor accessed the distal SFA using fluoroscopy, crossed the lesion with an 018 glide gold wire, wired into the antegrade sheath, and externalized it through the left.
This wasn't this morning, right?
Yeah.
It wasn't this
Similar
morning?
case. So use an 035 Navicross over the externalized wire in an antegrade fashion beyond the CTO distal cap. And what now?
So can I just go back for 1 sec? Just, I know this is, endovascular. I'm an interventional cardiologist. I'm not a vascular surgeon. But in our institution, and I talk with Mary often about this, before I do a case, I actually ask the fellows, give me a reason why this patient should not have a bypass. And the reason why I go through that exercise is because I think that endo has come a long way. But if you look at the data of any of these devices that we have available, whether it's a drug-coated balloon, whether it's a drug-eluting stent or a bare metal stent or any of those, none of those devices have been tested in a patient like this. So in a patient like this, we probably don't have any data. So if I'm going to put or do an endo intervention, I want to make sure that what has been tested, which is someone who has a nice vein and above the knee bypass, is for some reason contraindicated. And I think that the fact that we can cross it and the fact that I can angioplasty and stent, it doesn't mean that I have to do that every single time. And I think that it is important that we take that into consideration before we come up with all these different algorithms, because there's no data to do any of these things, in this patient in particular. Just 2 sentences.
So to that point, Sean, you mentioned that this would not be a high-risk candidate, and this would be an average risk candidate. Would you take this patient for bypass? What would you think about?
So I would see if he had vein ahead of time. I would still primarily attempt to treat it endo, but I probably would not work really hard if I couldn't get across it easily. So I do believe if I'm not going to lose a collateral or burn a surgical approach, I would do endo first. but I want to know what their conduit is like, because the better their conduit, the least, I will spend a lot less time than if someone has poor conduit. If they have poor conduit, I'm going to throw the book at them.
All right, I'll ask the next question. If you choose atherectomy in this case, which device would you use? Maybe we could open that up to the panel as well.
E.
E.
None of the above?
None of the above.
So kind of all across the board. So in this case, we used a Turbo Elite laser, treated the entire segment, and then treated the length of the disease with 3 DCBs. Got a nice final result.
I think
I
that,
don't
you know,
if I would
it's,
use
you know,
nice.
this case is.
What do you think of that proximal SFA? That osteo SFA doesn't look that hot.
Actually frequently do FFR and
Yeah.
hemodynamic assessment. I think as we are moving more towards DCB and the idea and the concept of not using stents. So we have moved more and more towards FFR in these lesions and making sure there is not a significant gradient. I think going back to a discussion that that we had, that Carlos mentioned, my own approach, I think, in this is that, as Sean mentioned, I think we actually have a similar approach to these cases, is that if you can get a good endovascular result, I think it's appropriate to try that. Again, you always got to keep in mind that you don't want to harm the patient. Like the last live case that we did, I didn't want to compromise the common femoral, so I didn't do a lot of things that were being recommended because I didn't want to compromise the common femoral. So, and I think the field is moving towards that approach. Yes, we may not have all the data yet, but definitely the field is moving towards that approach that if you can safely do the endovascular approach, as mentioned, then it's reasonable to try the endovascular approach. And I think Dr. Walker did a very nice presentation this morning showing that, yes, if you don't do appropriate endovascular, you take out the surgical options. But if you do appropriate endovascular, you never take out the surgical options. So in this situation, is paying attention to the above-the-knee popliteal, because we are not going to damage that popliteal. We're going to be very careful. And that's one of the reasons we got retrograde access. We could have just extended the dissection, put a re-entry device, and just create re-entry and end up stenting it. But we didn't. We took the time of going to the pop, getting retrograde access, crossing the lesion in a retrograde fashion, because we felt that doing that would not compromise the distal target, and the patient would still have that opportunity in the future.
Hey, Mary, what's the cutoff that you use for your FFRs?
Because actually we are conducting a study in this cohort of patients. As you know, the lower extremity is different than the coronaries, and people typically have indicated to use the 0.8 FFR, which is completely wrong. As a matter of fact, if you do FFR of the periphery, the lowest you usually end up getting is in a 0.9 range, unless you have occlusion. So if you use the FFR versus the peak-to-peak gradient, you're going to get different results. So the differential is very incremental. So what we use here, for the FFR, at least based on our experience, and also based on the research protocol that we have currently, and we have about 10 patients in it, where we are doing FFR of these lesions. In addition, we are giving different hyperemic agents, so nitrite and piperacin, both, and trying to see when is the peak hyperemia in these patients. The other approach is to do toe raises while they're in bed, and do that and see if you can get a gradient with kind of an exercise in these. So far I can tell you that what we use for the SFA is a peak-to-peak of 20. Peak-to-peak of 20, and for FFR we use 0.9. So if it's less than 0.9, but I think very soon we're going to be able to correlate this and give you the data from what we have based on external ultrasound, based on hyperemic data with the FFR, and hopefully we can provide some additional information. But I can tell you, the reality of this field, and I don't mean to talk the whole time, but I think this is good discussion. The reality of this field is that if we had the European guys, they leave type D and E dissections alone when they treat these patients. So there is some heterogeneity out there in regards to how we're practicing in Italy, in Germany, and what we do in US, and even in the United States. So that's why I think trying to be more objective about it, rather than subjectively looking at this and saying, oh, it's not a bad dissection, it's not flow limiting, or that the SFA and the profunda feel at the same time. I think these are very subjective. I think we got to move more and more towards FFR-guided objective assessment.
Sahil, you have one last comment?
Yeah, just curious about how you correlate with your non-invasive studies after they come off the table.
Yeah, so that's a little bit challenging. So what we do a duplex ultrasound beforehand, we do duplex ultrasound afterwards. And again, we use the 0.9, and what we typically have done in these, as I said, we're trying to identify as a first step, what is the hyperemia that need to achieve? So the question is that, is it 10, 20, is it 30 of papaverine, is it 60, is it 10 of nitrite, 20 of, we're at that stage. And as you know, a lot of folks put a 4 French, 5 French catheter, which many of us believe that might not be accurate. So we are at this stage where we're trying to, as best as we can, obviously, ideally would be intra-procedurally to do the duplex. So do the FFR, do an intra-procedural duplex, see what the peak systolic velocities are, and see what the correlation is between the FFR and external ultrasound peak systolic velocity. I think that probably would be the most informative, but it's a little bit time-consuming and challenging from a standpoint of sterility.
And the other thing is that the physiologic situation changes from the procedure to post-procedure. And even the day after the procedure is different than the week after the procedure, in my experience, that you sometimes don't feel pulses even the next morning, but then the next week, when things have smoothed out in the lesion and so on, a week later, you get a much better ABI and a much better pulse. So I think this is just a very, very tricky area, Mehdi. At the end of the day, outcomes are what matter. Functional outcomes, healing of wounds, those are the most hard endpoints. But, yes, we need to explore all these other things too.